Hello fellow doctors and anesthetists. Today we are going to discuss respiratory physiology and we will go step by step. So the first step is red blood cells and hemoglobin. So we'll start with RBCs and hemoglobin. So the process of RBC production is known as erythropoiesis. Erythropoietin is the hormone which is responsible for synthesis of RBCs and it is secreted by the kidneys. RBCs mature in bone marrow and they take 7 days for maturation. The various stages of RBC maturation are proerythroblast, prorubrocyte, normoblast, reticulocyte, and then erythroblast. Now the stages reticulocyte and erythroblast, they do not have a RBC. Conditions which cause hypoxia such as high altitude, COPD, they release erythropoietin from the kidneys and this causes increased production of RBCs. The life of RBCs is 120 days. During these 120 days, they undergo wear and tear, and then they are finally sequestered in the spleen where they are broken down. Now, when hemoglobin is broken down, it gets split into heme and globin components. The globin chains are broken down into amino acids, and the heme gets broken down into iron and biliverdin. Iron is then transported to muscle, liver, and other tissues, and biliverdin converted to bilirubin and is excreted into bile via liver. Now, what is the function of hemoglobin? It is responsible for transport of oxygen. Oxygen is transported in two forms. One is dissolved form, which is only 1.5%, and the other is bound to hemoglobin, which is 98.5%. Now we'll discuss the structure of hemoglobin. It is a tetramer, consists of 4 heme and 4 globin chains. Now a heme group consists of a central iron atom around which the entire molecule is arranged, and this is known as porphyrin. And there are different forms of hemoglobin. The adult hemoglobin, it consists of 2 alpha and 2 beta chains. Fetal hemoglobin consists of 2 alpha and 2 gamma chains. And the HbA2, the second type of adult hemoglobin, consists of 2 alpha and 2 delta chains. At birth, most of the hemoglobin is fetal hemoglobin, but at around 6 months of life, all the fetal hemoglobin is replaced by adult hemoglobin. Now we'll discuss some disorders of hemoglobin. First is sickle cell disease. In the beta chain, glutamic acid is replaced by valine. This leads to a change in structure of hemoglobin such that whenever hemoglobin is exposed to low oxygen tensions, it polymerizes, and this causes sickling of RBCs. It is an autosomal recessive disease, and whenever there is sickling of RBCs, it leads to painful crisis and infarcts. The second disease is thalassemia, where there is a decreased synthesis of hemoglobin chains. If there is decreased alpha chain, it is known as alpha thalassemia. If there is decreased beta chain synthesis, it is known as beta thalassemia. Now this is also an autosomal recessive disorder. Now we'll discuss the binding of oxygen to hemoglobin. Oxygen binds to the ferrous iron in the hemoglobin by a reversible bond. Now each hemoglobin molecule can bind to 4 molecules of oxygen. A deoxygenated hemoglobin is in a taut form and it has less affinity for oxygen. However, as oxygen binds to hemoglobin, its affinity for oxygen increases and it finally comes into a relaxed form which has higher affinity for oxygen. Now there are other factors which influence the binding of oxygen to hemoglobin. These are pH, PaCO2, 2,3-DPG levels, or any diseased or physiological states. These will be discussed later. Now we read that oxygen is carried in 2 forms. One is dissolved, which is very low, it is only 1.5%, and the other is bound to Hb, which is 98.5%. Now, however small this dissolved form is, it is still very important in disease states. For example, in severe anemic patients who are Jehovah's Witness and we cannot transfuse them with blood, we can increase this dissolved oxygen by increasing the partial pressure of oxygen in the blood by giving a high FiO2. This dissolved oxygen is also responsible for triggering the hypoxic drive. This is important in COPD patients where giving oxygen will suppress their respiratory drive. And so it is recommended that in most COPD patients being treated in the hospitals, the target SpO2 levels should be around 88 to 92% so that their hypoxic drive is intact and do not go into apnea.